Hi guys, now we'll be discussing with very important topic, that is autopsy. Right? So we'll be discussing on what is called as autopsy. Why this topic becomes important and why should you learn in UG? Right? You might think only forensic medicine experts are doing medico-legal autopsy. It is not so. See, in India, most of the medico-legal work, particularly this autopsy, you can see majority of the work is done only by the MBBS doctors. If you ask me what is the eligibility for a doctor to do this autopsy, medico-legal autopsy, it is only MBBS. Any registered medical practitioner with MBBS is eligible to do autopsy. Right? You need not get any kind of specialization. Right? Here it is only MBBS is the degree that you need. Right? You should be a registered medical practitioner and you can do medico-legal autopsy and you will be doing autopsy in your career. Right? Right. Now let's discuss what is autopsy and what are the different autopsy that we have got and what are the different important steps that you have to know, procedure that we have to know from examination point of view. Right? See, autopsy is also called as post-mortem examination. You know, post-mortem after death examination. It is also called as necropsy. Necro means dead body. Opsy means study. It is necropsy, study of dead body. It is also called as thanatopsy. Thanatopsy. What is the thanatopsy? Again, study of the dead body. It is also called as sectio cadaveralis. Sectio cadaveris. Basically, it is we are dissecting the dead body to study it. So these are all the different synonyms that we have got. Not so important for examination perspective, but it is important for general knowledge. Right? Now, see, basically in India, we have one common autopsy, one very common autopsy that we have got. We call it as medico-legal autopsy. Medico-legal autopsy. And primarily, there is one more autopsy, that is your clinical or pathological autopsy. Clinical autopsy or pathological autopsy, or you can also say academic autopsy. Academic autopsy. So these are all the two. These primarily we have these two types of autopsies there. Though you have lot of other types also there, we'll be discussing in detail. But now for discussion purpose, these are the two broad types of autopsy which are relevant here. Now this medico-legal autopsy, underline the word medico-legal. It is related to medico-legal cases. Right? In what kind of cases that you can do medico-legal autopsy? Medico-legal autopsy is done in unnatural death. Right? You can say medico-legal cases, unnatural death, whether it is accident, homicide, suicide, suspicious death, you do this autopsy that is called medico-legal autopsy. What is the purpose of doing this medico-legal autopsy? Why do you want to do it? What is the objective of this medico-legal autopsy? The objective of medico-legal autopsy is that you have a number of objectives are there. Let me tell you one by one. Number one, identity. Sometimes if the dead body is completely decomposed, you don't know who's that person, or sometimes if the body is completely mutilated, right, or if the body is completely charred out, right, in all these cases you need to identify who's the victim, right? So identity is another important point. This one, first objective is identification of the victim. Second thing is to find out the cause of death. You need to find out why the person died. Right? Manner of death. What do you mean by manner? See, manner means basically either it is natural death or he died of unnatural death. Only two types basically. Natural or either he died of natural death or he died of unnatural death. If it is unnatural, is it accidental, homicidal or suicidal? If it is unnatural, is it accidental, homicidal, suicidal? That is called manner of death. So you want to find out the manner of death by doing this autopsy. Right? If you see any injuries, right, in the body, you want to document all the injuries and you need to find out what is the basic characters of the injury, what is the type of injury that is got, and is there any other information that you can obtain from the injury. So you need to do injury examination, and if you are able to see the injury, and you also can find out what is a weapon, what is the type of force that can cause this type of injury. Right? If the person could have died of poisoning and you want to find out which poison the person died of. Right? And the next objective is in case of fetus. So far we were focusing on the adult examination of body. Now if it is fetus examination, in addition to all these things, you will have one more important objective, that is to find out whether it is a case of live birth or dead born. Right? You can also find out whether it is stillborn, live born or dead born. You want to know whether the baby is born alive and started breathing. Right? So if the live born baby has died, maybe it is a case of crime. If it's a dead born baby, right, no problem. It is already dead inside the uterus, so no problem, right? So you want to find out whether it is a live born case or a dead born case, and you will also be commenting on whether the fetus is viable or not, right? Whether the fetus is viable or not. Viability, we'll be discussing that later. For now, you remember, in a fetus examination, we will be focusing on whether the case is a die-born case or a dead-born case. And the last objective is to find out the evidences and to collect the evidences, and you need to preserve the evidence appropriately, forward it to the appropriate agencies. Right, you want to forward it to appropriate agencies so that these evidences will be useful for the investigation process, right? And in sequence, it is useful for the court case, the trial, right? So these are all the objectives that we have got in medico-legal autopsy, right? I told you this is mainly done in unnatural death. Now, see, if you want to do medico-legal autopsy, somebody has to authorize you. Right? Somebody has to authorize you. Who can authorize you? Remember, this authorization, you can start doing this autopsy only after getting authorization from the investigating officer. Right? IO means investigating officer. We discussed it earlier. I did not specify whether police or magistrate, because you know very well that it may be a police inquest or it may be a magistrate inquest. Depending on what type of inquest, that particular investigating officer will give you requisition letter. Right? Please do autopsy and to find out the cause of death in this body. Right? Once you get the requisition from the IO, you can directly start doing this autopsy. Do remember, in this case, when you are doing medico-legal autopsy, no need of relatives' consent. I have already told you the same thing in consent section. Do remember, if it is medico-legal autopsy, there is no need of relatives' consent. You have already gotten, see, the law gives you consent. The law, Indian law gives you consent for medico-legal autopsy. You have gotten the authorization from IO. That is sufficient. You can go ahead with the autopsy. Right? You can go ahead with the autopsy. How about examination? Right? How about examination? Do you want to examine in detail? You want to examine all the cavities of the body, or you want to focus one specific part of the body where you suspect some lesion? I repeat, do you want to examine all the cavities of the body, all the primary cavities of the body? When I say primary cavities, abdominal cavity, thoracic cavity, cranial cavity. Right? Do you want to examine all the three cavities of the body completely, or do you want to focus only on the cavity where you suspect some lesion? Right? If it is medico-legal autopsy, do remember the examination should be a complete autopsy. Right? All the three primary cavities have to be examined. A case of head injury is brought to you for autopsy. Which of the following cavity that you need to examine? Cranial cavity, option A cranial cavity, option B abdominal cavity, option C thoracic cavity, option D all the above. If it is medico-legal autopsy, all the cavities have to be examined irrespective of the case. Remember, all the three cavities have to be open. Medico-legal autopsy always has to be complete autopsy. Now, you have completed autopsy. Whom will you hand over the body? Right? Handed over to whom? Whom will you hand over the body? Do you want to hand over to the dean? Do you want to hand over to the court? Do you want to hand over to the IO? Or do you want to hand over to the relatives or the parents, legal guardian of the body? Remember, here, who gave you the authorization? Here, the legal person that is having the control is the IO. Who gave you the requisition? The IO. So after completion of the dissection, after completion of the postmortem examination, you need to hand over the body back to the IO. Right? You're not supposed to hand over to the relatives. The IO will hand over the body to the relatives. Right? So this is medico-legal autopsy that you need to know primary points about medico-legal autopsy. Talking about the clinical, pathological or academic autopsy, do remember in this case, you just have to do this pathological autopsy is normally done in unnatural death. See, pathological autopsy is normally done in natural death. Medical autopsy is done in unnatural death, whereas pathological autopsy is done in natural death. Right? Now, who will give you authorization? Who would get you authorization? See, what is the need for this autopsy? First of all, the person died of natural death. There is no question about the cause of death. You know it is natural. Then why do you want to do this autopsy? Why do you want to do this examination of dead body? Why do you want to do dissection? Though you know it is natural death, you want to find out what is the pathology he died of. Right? What is the cause of death? What is the pathology? That is the reason why you do this autopsy. This is called pathological autopsy, also called as clinical autopsy. right? Person was died of natural death, but we didn't specifically know from which disease he died of. You want to know the pathology, and you are doing this dissection, that is natural death, clinical autopsy. Right here, the IO doesn't come into the picture at all because it is natural death. In this case, who is the authorized person for this dead body? It is the relatives. So only after getting consent from the relatives, you can start the dissection. Right here, this consent of the relatives, it is compulsory, mandatory. Without the consent of the relatives, you can't even touch the body. That is again very important. Fine. Now, examination. When it is talking about only pathological purpose, academic purpose, right? We want to know the cause of death. Wherever that you focus, suppose you suspect the person must be having thoracic lesion, you open only the thoracic cavity, that is sufficient. If you suspect there is some cranial lesion, you open only the cranial cavity, doesn't matter. Right? So it need not be a complete autopsy, it can also be a partial autopsy. Right? Wherever you suspect, wherever you think the lesion is in, you can open only that particular cavity. You need not open all the cavities together. Right? And here, whom will you hand over the body? Who gave you the body? The relatives. You need to hand over the body back to the relatives. Right? Back to the relatives. So which is the most common type of autopsy in India? If they ask you, the most common type of autopsy in India is medico-legal autopsy. Right? The pathological autopsy is not quite common in India. Right? If you go to Western countries, pathological autopsy is very common, wherein the relatives and the family members would like to know what is the pathology that is causing death of their loved ones. Right? Remember, see, in India, the medico-legal autopsy is the most common type of autopsy in India. But we should also know what are the other types of autopsy available. Number one, it is called virtual autopsy, which is also called as virtopsy. Right? It is called virtual autopsy. It is also called as virtopsy. What do you mean by this? See, this is basically virtually done. It is not basically dissection. If it is not basically dissection. What you do is you do imaging technique, complete imaging of the body. It is basically imaging. You are not doing dissection. What are you doing? You are either taking CT scan, or you are taking MRI scan, or you are doing 3D optical measurement techniques to assess the status of the organs which is present inside the body. You will also like to know what is the disease process that is happening in the body, or you would also like to know whether there is any injury present in the body tissues. With the virtual techniques, imaging techniques, you are not doing any dissection. If at all you suspect something, with the image, if at all you suspect something in a particular cavity, if you want, you can just dissect only that particular region. That is why this is called minimally invasive technique. Right? Minimally invasive technique. Not always non-invasive technique. Sometimes it can be minimally invasive technique. You suspect in the imaging, you find a lesion in the particular region, and if you want to find out what is the nature of it, benign, malignant, whatever it is, you want to take a sample from that, you can do the dissection only in that particular region. So it can be a minimally invasive technique. There is one important disadvantage with this virtual autopsy, that is this virtual autopsy will be telling you only about the structural lesions, not the functional lesions. For example, which of the following cause of death cannot be identified with the virtual autopsy? Option A, cardiac tamponade. Option B, rupture of spleen. Option C, ruptured biliary aneurysm. Option D, death due to hypoglycemia. Remember, death due to hypoglycemia cannot be visualized in the image, so you cannot find out from the virtual autopsy. So only structural lesions can be identified by virtual autopsy. Functional lesions cannot be identified. This is one important point about virtual autopsy. There is one limitation. Right? Now going forward, the next important type of advanced type of autopsy is endoscopic or keyhole autopsy, wherein just like endoscopic surgery, where you pass an endoscope, here you are passing endoscope or laparoscope. Right? When you are passing endoscope or laparoscope, you can see the internal organs. You can see the internal organs inside the cavity. Based on that, you can give the opinion. Here, the body is intact. You are not disturbing the architecture of the body. You are not disturbing the architecture of the body. This is very restricted type of autopsy. You are not doing an exhaustive autopsy like your medico-legal autopsy. It's a very restrictive technique. You have got very restrictive approach. Right? Then we have got needle autopsy. What is that needle autopsy? If you want to take a sample, if you want to take a sample, or if you want to take a tissue sample from a particular place or a particular tissue, you can use biopsy needle to take the samples. Right? And in this needle autopsy, what they do is you take samples from different tissues, what are the tissue that you would like to examine. You can take the sample from different tissues, various sites, and subject it for examination. That's called needle autopsy. You are using needle. That's all. Needle autopsy. Biopsy needle. That's why it's called needle autopsy. Then what is that psychological autopsy? This is very important. This psychological autopsy, this is done whenever there is a doubt regarding manner of death. Whenever there is a doubt regarding manner of death, then you can do this psychological autopsy. Whenever the manner of death is in doubt, right? You know, one person, he was talking to you nicely. Next day morning, you find him, he was found hanging from the ceiling. Some people say it is suicide. Some people say it is murder. You are not sure whether the person has committed suicide or not. For that, you can use a psychological autopsy. This psychological autopsy is basically to assess the deceased state of mind. Deceased means dead person, right? The dead person's state of mind before committing suicide, before committing the death. This is basically to confirm suicidal death. How can you do it? You need to conduct interviews. With family, friends, right? Family members, and you can do it with relatives or friends to assess the mind status of the person before committing the death, right? You can ask the family member, they'll say, yes, he was already under depression, severe depression, he was taking antidepressants, and he has already attempted so many suicidal attempts. Fortunately, we escaped. We got him out of the suicidal attempt. But unfortunately, this time we could not see it, and this person committed suicide, and he died. You talk to the family members, find out what is his mental status before committing suicide. So you conduct interviews with the family members and relatives. You talk to the family member. The family members will be telling you, sir, he was already under severe depression. He was having antidepressant drugs, medications, right, which he was not taking properly. He has attempted multiple times suicidal attempt. We tried to save him every time, but unfortunately this time we could not save him, we lost him, right? The family members, you conduct interviews with the people around him, and you will be able to comment whether, you will be able to confirm whether it is suicide or not. That is called psychological autopsy. The next type of autopsy is called verbal autopsy. This verbal autopsy is basically used whenever you don't have any kind of certificates. What they do is they do structured interviews, right? A set of qualified people, they do structured interviews with the families and relatives. The family members mostly. The family members will give data for us. The family members will tell you the history, right? How he was there at the time of death, just before the death, whether he was suffering from any specific illness or not. The data given by the family members through the interviews, from this, we can find out the cause of death, right? The cause of death is determined from the data given by the family members through the interview. That's why it's called verbal, right? This is not so accurate. This is basically used for statistical purpose. Right? This is basically used for statistical purpose, nothing more than that. That's called verbal autopsy. I've told you the various types of autopsy, but do remember here what is the most common type of autopsy. The most common type of autopsy is medico-legal autopsy in India. Right? See, normally what we do, we take history of the case, right? We do external examination, right? And then we do internal examination. Based on the findings, if needed, we go for the additional lab test. Right? Based on all these findings, finally we arrive at the opinion. Right? Finally we arrive at the opinion. Suppose if the findings of the internal examination and the external examination is conclusive, you don't need to go for additional tests. If you feel that additional test is needed for the case, then you can go for additional test. Based on all the findings, you tell the cause of death. There is one important type of autopsy that is called obscure autopsy. What is that obscure autopsy? Obscure means something which is hidden. The literal meaning of the word obscure, right? Obscure autopsy. Wherein you do external examination for a case. You do internal examination for the case. In both the situations, what happened? There is no significant finding at all. It is so insignificant. Or the findings are so minimal, you cannot give the cause of death only with that particular finding. Not possible, right? And suppose in this case, you cannot give the cause of death. You may go for additional lab test, right? You may ask the history of the case, clinical history of the case. You talk with the family members, conduct interview with the family members, conduct interviews with the eyewitnesses of that particular circumstance when he died, right? With all these things, you can come to the opinion that is called obscure autopsy. That's called obscure autopsy, right? Now what happens? You can see there are a lot of cases like that. You can see vagal inhibition of heart. You don't get any specific findings at all. Vagal inhibition of heart. You can say there is epilepsy, status epilepticus. There is no specific postmortem findings. Paroxysmal fibrillation. There is no specific finding. Patient died of uremia. Patient died of diabetes. You don't get any specific finding. In that case, this is called obscure autopsy. Obscure autopsy, wherein you get only and only minimal findings during dissection. When you get minimal finding during dissection, insignificant finding during dissection, then it becomes very difficult to tell the opinion. We call it as obscure autopsy. There is one more autopsy. There is one more autopsy where you call it as negative autopsy. Negative autopsy. Right? What is that negative autopsy? Negative autopsy, you can imply it from the term itself. Negative autopsy, right? Everything is negative. What is that negative? Used to in external examination, there is no finding at all. There is no significant finding. Nil finding. And you do internal examination, there is nil finding. Negative. No findings at all. You do all the tests. Again, no result. No specific result. Can you give the opinion about the cause of death? You cannot give the opinion about the cause of death. You can only say the cause of death in this case cannot be determined. Cannot be determined. You cannot tell the cause of death. That is called negative autopsy, wherein you give negative opinion about the cause of death. What is the negative opinion? You are not able to find out the cause of death. If you tell the cause of death, that is positive opinion. Here, you are not able to tell the cause of death. That's why it is called negative autopsy, negative opinion and negative autopsy. As simple as that. If you do this case, if you take 100 cases, 2 to 5% of all autopsies can be negative. Possible, very much possible. 2 to 5% of that is the incidence of negative autopsy. Right? It's very much possible that 2 to 5% of all autopsies can be negative, wherein you will not be able to comment on the cause of death. That is all negative opinion, negative autopsy. Right? Fine. Let's go forward. Let us talk about the examination, that is post-mortem examination of the dead body. Right? Before you start the dead body, somebody has to identify. This is medico-legal autopsy. Who will do the identification of the dead body? You need to identify whether it is Ramesh or Suresh or Raju or Ramu. You need to find out. You cannot do directly go to the case. You can start doing dissection. It's not possible, right? Somebody has to identify this is the dead body wherein you have to do dissection, right? Who will start doing this identification? Identification will be done by the police, right? Or some IO, right? Once they give the requisition, once they identify the body, then you can start doing this autopsy. Now, let us start doing the examination. To start with, let us focus first with external examination. First, we do external examination. External examination will be primarily towards identifying any injury present or not, documenting whether any injury present or not, or your external examination will be focused towards any post-mortem findings. Maybe rigor mortis, all these mortis, post-mortem decomposition changes, all these post-mortem changes will be focusing on this external examination. Primarily, the post-mortem changes will be helping you towards time sensitive, primarily. Other additional information will also be there. We'll be discussing on that later, subsequently. But here we'll be focusing on two things, injuries and the post-mortem changes or any other feature present in the external examination. Right? Now, moving on to internal examination. Right? Internal examination. When you're talking about internal examination, which cavity that you would like to start with? What is the first cavity that you would like to start with? As I told you, 3 primary cavities. As I told you, we have 3 primary cavities: cranial cavity, thoracic cavity, abdominal cavity. Which cavity that you would like to start with? If somebody is asking you this question, you should always say it depends on the person who dissects. Right? It depends on the choice of the autopsy surgeon. Right? It depends on the choice of the autopsy surgeon. You cannot have one rule for all the case. Not possible. Right? It depends on the choice. It depends on his choice. Right? Fine. Most commonly, we can start with thorax. And again, up to you. It's up to your choice. If you are the person doing autopsy, you can decide which cavity that you can start with, depending on the case. Right? Depending on the case. But there are few rules that you have to follow. What are the few rules? Number one, if it is a case of poisoning, you need to start with the cranial cavity, because certain poisons will have specific smell. Particularly if you see cyanide will have bitter almond smell, wherein you need to open the cranial cavity. You can perceive the smell of the poison. You cannot say, sir, I will directly open the abdomen, I will open the stomach, open the gastric cavity, smell from the gastric cavity itself. That is not possible. You will not get accurate smell, because when you open the abdominal cavity, there may be decomposition gas which will disturb the smell of the poison. Right? So if you want to clearly find out the smell of the poison, the cranial cavity has to be opened first. Right? Next, case of head injury. A case of head injury. You would like to start with cranial cavity, head only. You would like to start with the head. Head injury, head. Right? Because you want to focus first on the head region, because the injury is there. Right? And what about asphyxial death? This is very important. Asphyxial death, what are the examples of asphyxial death? You have a long list of asphyxial death: hanging, strangulation, mugging, garroting, banzola. You have a long list of causes. Right? Whenever you do dissection in asphyxial death, do remember, you want to examine the neck in detail. Because there may be some injuries. For example, if you take manual strangulation, you also call it as throttling. There may be injuries present inside the soft tissues, neck region. Right? If you want to examine the neck clearly, you need to see the injuries alone clearly. If you want to see the injuries alone clearly, should you have a field with blood or should you have the field without blood? Yes, you need to have a field without blood. We call this as bloodless dissection. Right? We call this as bloodless dissection. Sometimes in asphyxial death, basically, there can be blood congestion in the neck region. We call it, it may cause confusion. Right? There can be some blood congestion of the blood in the neck region. It may cause confusion. That is called Prinsloo-Gordon artifact. Prinsloo-Gordon artifact. Right? And if you get this Prinsloo-Gordon artifact, you cannot examine the neck clearly. It will cause confusion. So you want to avoid this Prinsloo-Gordon artifact. If you want to avoid this Prinsloo-Gordon artifact, you need to have a bloodless dissection. Now the question is, how will you have bloodless dissection? If you want to have a bloodless dissection, to start with, you need to start with the cranial cavity. First cavity to start with. Then you open the remaining cavities of the body. You can open thorax, you can open abdomen, and finally you need to come to the neck. Neck will be the last part to open. Right? You can ask me, sir, throttling, it is a case of manual strangulation. Neck is the most important region. Why won't I start with the neck? If you start with the neck, there can be lot of blood. It will cause confusion in the neck. You want to have a bloodless dissection. Open the cranium first, then open the thorax and abdomen next. Come to the neck at the last. When you come to the neck at the last, by the time when you open the thorax, abdomen and cranial cavity, all the blood is drained from the body. When all the blood is drained from the body, finally you come to the neck at the last, you will have bloodless dissection. When you have a bloodless dissection, you can easily find out even the small injuries. Right? If you want to find out the injuries very clearly in the neck, you need to have a bloodless dissection. For that, head has to be opened first and neck has to be opened last. That is what you need to remember. Asphyxial death. Right? The next thing is your newborn babies, neonates, newborn babies. Babies just born, died. You want to know whether the baby is a live born or dead born. You want to know whether the baby died inside the uterus itself or it is born alive, started breathing, then it is dead. Right? You want to differentiate whether it's a live born or dead born. If you want to differentiate whether it's a live born or dead born, remember what is the first cavity that you need to open. The first cavity that you would open is abdomen. Right? You need to open the abdomen first. So why would I open the abdomen? What is the relationship between lung and the abdomen? Remember, when you open the abdomen, insert your fingers, look for the dome of diaphragm. Right? Look for the dome of diaphragm. What happens if the baby has started breathing? right? This is the baby which has not respired. You can see the diaphragm will be at the level of third or fourth rib because the lung is not expanded, lung is collapsed. Now, if the baby started breathing, lungs will expand. Lungs will expand. The expanded lung will push the diaphragm down. You can see that the diaphragm is pushed down. It will be at the level of 6th or 7th rib. Right? It will be at the level of 6th or 7th rib. That is because expanded lung is going to push the diaphragm down. It will tell you whether lungs are expanded or not. That is the reason why you open the abdomen first in a newborn baby. Right? So that is about newborn baby. Right? Moving further. What about a case of pneumothorax? If it is a case of pneumothorax, you know what is pneumothorax? Presence of air in the pleural cavity. We open the thorax first. Why do you want to open the thorax first? What I'll do is, I will open the skin, right? Open the skin flap, right? Pour some water into the pocket, right? Between the skin and the rib, right? Air will be there. Under the water, I will take a knife, surgical knife, puncture the intercostal space and the pleura. When I'm puncturing the pleura, what should I see in the water if it is pneumothorax? If it is pneumothorax, in the water, I should be able to see the bubbles coming out. So I will be demonstrating the pneumothorax, the air in the pleural cavity, by opening the thorax first. Right? By opening the thorax first. Do remember in a case of pneumothorax. The next important condition is air embolism. See, when we say air embolism, it can be a venous air embolism or it can also be a systemic air embolism. Right? If it is a venous air embolism, which is very common, venous air embolism, this is common. Systemic air embolism. Systemic air embolism is where first we open the cranial cavity, we are inspecting the intracranial vessels. We are inspecting the intracranial vessels for the presence of air bubble along the vessel. If it is systemic. But if it is venous, what we do is we open the thorax first. We open the thorax first. After opening the thorax, let us assume that this is the pericardial cavity. And inside the pericardial cavity, what have you got? You have got heart. Let us say this is the heart. Fine. What we do is you open the sternum. You can cut the pericardial membrane. When you cut the pericardial membrane, what you can do is you can either fill the cavity with fluid, water, then puncture through this. Puncture the ventricle. When you puncture the ventricle, if at all there is air, that will be seen in the water level as a bubble. If at all. Right? This is one way. Another way is that you can take a syringe. You can take a syringe with wide bore needle. You can take a syringe with wide bore needle which is containing pyrogalol solution. Remember the term, it is pyrogalol solution with sodium hydroxide. So you can have pyrogalol solution, 2% pyrogalol solution with sodium hydroxide, no matter about that percent and all, just no pyrogalol solution with sodium hydroxide in a syringe, wide bore needle. You have cut this area, you have cut the pericardial membrane. Now insert the syringe with the needle. Aspirate from the ventricle. Aspirate from the ventricle, then you can close the needle, shake it. When you shake it, what happens? If at all, if there is any air in the ventricle that would have been aspirated into the syringe, when you shake it, it mixes with the pyrogalol solution. When it is mixing with the pyrogalol solution, you get a color change, you will get a brown color. Right? The presence of this brown color will tell you it is positive for this test. Remember, pyrogalol test. This is called, we are using pyrogalol solution. That's why it is called as pyrogalol test, which is used for demonstrating air embolism, which was asked in one of your previous year exams. Right? Remember, pyrogalol solution. Fine? Pyrogalol solution wherein you get brown color. The color is also important. So this is about the different cavities in different conditions that you need to open first. Now, let us see, we are going to open the body, we are going to put incisions and we are going to start examination. When you have incision, you can say primarily it has got 4 types of incision. You have got primary incision, we have got secondary incision, we have got tertiary incision, we have also got quaternary incision. Quaternary incision. We have got primary, secondary, tertiary, quaternary. The one which we apply on the external skin, that is called primary. Very simple. After opening the skin, we have to cut the sternum, the ribs, costal cartilages, and we have to open the skull vault, right? Opening the skull vault, right, and the ribs, that is secondary. Now, before examining the organs, you need to cut the serous membranes. You need to cut the serous membranes. That is tertiary. What is quaternary? After doing all the things, you take the organs out. You take the liver out. You take the kidney out. You take the spleen. When you take the individual organs, start putting incisions on the organs. That is quaternary. That is quaternary. So I have told you primary, secondary, tertiary, quaternary. Here you can get questions in any of this, right? You can get question in any of this. You have gotten questions in all the things earlier. First, let's focus on the primary incision, right? Let's talk about the skin incisions that we have got. Skin incisions, right? Skin incision. The skin incision, my discussion is towards, right? It is based on the essentials of forensic medicine and toxicology by Naran Reddy, right? And it is also based on the review of forensic medicine and toxicology by Dr. Gautam Biswas, right? I have taken these two textbooks as reference, and my incision discussion will be based on that. Okay, fine. Now the first incision is what is called as eye incision. The first incision, what is called as eye incision, wherein you start from the chin. Let us say this is the neck of the person. This happens to be the neck of the person. You can see the chest and the important organ umbilicus, right? Fine. So this is and this is, let us say this is pubic symphysis, and here is where you have chin. If you have the skin incision, central midline incision starting from the chin, go down vertically, right? Go down vertically in the midline, avoid the umbilicus, go to the pubic symphysis. Why do you want to avoid the umbilicus? Because when you are suturing, umbilical is a cicatricial tissue, that is scarified tissue. It is very difficult for the needle to enter, very difficult to suture. So avoid the umbilicus. You can have a central midline incision. This is called eye incision. Eye. Right? Eye incision. And this happens to be the very easy incision. With a single incision, you can open neck, thorax, abdomen, everything. That's why it is the most common incision. Very easy incision that we have got. The second incision is called as Y incision. This Y incision, you can remember this Y incision, you start from, right? You start from the acromion process shoulder, below the breast, it comes to the chest. It meets in the xiphoid process. It comes below the breast, meets in the xiphoid process. From there, it is brought down to the pubic symphysis, right? It starts in the shoulder, meets in the chest, comes down to the xiphoid process, comes down to the pubic symphysis. That is called Y incision, right? Remember Y incision. This is one of the cosmetical incision, right? Preferably, I told you it comes under the breast. So suture will be under the breast itself. Maybe it is used cosmetically. It is better, useful for females. Females. The third type of incision, this is called modified Y incision. Right, this is modified Y incision. This is modified. You can see that, right? You can see that the incision starts in the mastoid process on both sides. You start the incision in the mastoid process on both sides, right? On both sides, it meets in the suprasternal notch. It meets in the suprasternal notch. From there, it is brought down to pubic symphysis. Right? From there, it is brought down to pubic symphysis. Now, this is called modified Y. You can remember from the first letter M, it refers to mastoid process. But do remember, I have just told you 3 incision. These are 3 primary common incisions. But if you see these 3 incision, which of these 3 incision will help you to have a detailed examination of the neck? I, Y, modified. Yes, this incision will be helpful in detailed examination of the neck. You can prefer it for asphyxial cases, asphyxial deaths. Asphyxial deaths. right? The next incision that we've got is T incision. T. What is the T incision? In this incision, what we can do is, in T incision, right, you can start with, it is basically from one acromion process to another acromion process, right? It goes like that. It goes like that. Along the subclavicular line. Along the subclavicular line, it forms a trough, right? And from the midline, again you have till the pubic symphysis, looking like T. That is why it is called T incision. It is also called as bucket handle incision. Bucket handle incision, right? This is called T incision. Bucket handle incision, also called as T incision, right? Bucket handle incision. Now this is all for adults. You can use it for adults, right? I'll tell you one more incision. That incision is useful for newborns. That is inverted Y incision, right? Inverted Y incision. What is that inverted Y incision? Inverted Y incision is something where you have, starting from the chin, it goes up to the level of umbilicus. Then from there it bifurcates to the mid-inguinal point. It bifurcates up to the umbilicus, then it bifurcates. This is called inverted Y incision. Inverted Y. All this is useful for the front of the body. Primary incision. There is one more incision that is called X incision. This is useful for custodial death. This is not put on the front of the body. This is put on the posterior surface of the body, particularly in a case of custodial death, wherein you would want to know whether there are any deeper injuries present or not, right? It is like a X, right? It's like an X. Fine. So it is put on the posterior surface of the body. See, in a case of custodial death, there can be chances of internal injuries. There can be chances of deep bruises, right? Because the person might have been tortured under custody. So you want to find out any deeper injuries present or not. You want to find out any deeper bruises present or not. For that, you open the entire limb and the back as an X-shaped incision. With that, you'll be able to find out whether any deeper injuries present or not. I can show you, this is your I incision. This is the most common incision that we have got. You can see this is Y incision. You can see this is your inverted, this is modified Y incision. Right, sorry, this is modified Y, IY modified Y. I told you I is most common. Fine. So let's go forward. After opening the skin, you would like to remove the organs out. We call it as organ removal technique. We call this as organ removal technique. What are the different techniques we have got? The first technique is where you can open the skin, you can take the organ one by one, organ by organ. Take the liver out, stomach out, kidney out, right? Spleen out, one by one. Take the heart out, lungs out. One by one you can start examining. That is called organ by organ. Organ by organ. Or you don't have time, you want to finish it faster, right? Or you want to study the inter-organ relationship. In that case, what you can do is make an incision, remove the tongue from the attachment, strip off everything. Take all the organs from the tongue till the level of anus, together as a single mass. Right? You can take all the organs together as single mass, keep it on the table, then you start examining. That is called en masse. All organs together. All organs together, we call it as en masse. I don't want all the mass together. For me, it is very difficult to handle. So I want to reduce the size. If I want to reduce the size, I want to focus one particular cavity, abdominal organ, abdominal block. Right? You can take the organs as a block. Right? We call it as block dissection. Right? Remember block. Now the point is, this is a case where I don't want to take the organs out. I want to reduce the time of exposure. I don't want to take the organs out. I can start examining without even taking the organ. I can start examining without even taking the organ. I can start examining in the body itself. You call it as in situ dissection. Right? That is called in situ dissection. So we have got organ by organ, we have got en masse, we have got block dissection, and we have also got in situ dissection. Now let me tell you the name of everything. Do remember, organ by organ, this is called Virchow's technique. Virchow's method. Remember, guys, this area is so highly important for examination. Very, very frequently that you get questions on this, right? In all the aspect that you have to know this area. Virtuous technique. All organs together in mass, this is called latules. Latules. How can you remember? You can see the first letter of latules, L for large mass. Large mass. Block dissection, that is called Gons. And inside the body, that is called Rokitansky method. That is called Rokitansky method. So virtuous, you have latules, you have Gons, you also have Rokitansky. So all the names I've told you. Right? When you're talking about organ by organ, see, every technique will have pros and cons. Every technique will have advantages, every technique will have disadvantages. Let me tell you what is the advantage of organ by organ. This is very easy. The most common technique that we have got. Most common technique that is practiced, that is virtuous. You can study the specific organ in detail. You want to study the liver, you can study in detail. You want to study the spleen, you can study in detail. But one disadvantage is you cannot study the inter-organ attachments and everything. That is virtuous. Because when you take one by one, like you are cutting everything and you are taking the organs out. Now coming to en masse. What is the advantage of en masse? You can have a rapid removal. Very less time. You can have rapid removal, but what is so important is the attachments are preserved, attachments are intact. Right? So you want to study the relationship, inter-organ relationship will be useful here. But what is the disadvantage of the latule method? It is such a big thing, such a big mass, it's quite difficult to handle. Quite difficult to handle. Right? Since you have all the attachments together, as I told you, if you want to study inter-organ relationship, so this inter-organ relationship, this will be very, very useful for you. Latules method. Right? And particularly in fetus, this is very useful because you can find out any malformation present or not. Right? Malformation, to find out, detect any malformation, this again will be very useful. Latules. I told you a disadvantage, difficult to handle, so big. So you reduce the size, that is Gone method. Right? Here, what can you do is you can either take cervicothoracic block, or you can take abdominal block, or you can take urogenital block. Right? You can take different block that you want. Called cervicothoracic, abdominal, or urogenital block. What is the advantage of here? This is easier than the latules method. This is easier to handle than latules. This is easier than latules. Latules is such giving you big thing, right? So this is easier than latules method. Fine. In situ method, Rokitansky, inside the body. Why do you want to dissect the organs inside the body itself? Because you want to reduce the exposure, because if the person has died of any infectious disease, for example, if the person died of HIV, if the person died of COVID disease, if the person died of hepatitis, that you want to reduce the exposure to the body, you want to do in situ, because you should not get contaminated with the HIV virus. Right? So in all infectious diseases, if you want to reduce the risk of exposure, you can do this in situ method. In situ method, infection, that is easy to remember. These are all the different organ removal technique that we have got. As I told you, this is one important mark fetching area. Very frequently you get question on this. Do remember this. Fine. Let's go forward. So let us continue with the head dissection. To start with, let's start with the head. Right? Head. Very important. No? So we'll start with it. You can see how to open the scalp first of all. What you can do is, you can put a bimastoid incision like this. Right? You need to put an incision from one mastoid, goes to the vertex, come to the other mastoid. So you will put a bimastoid incision. When you are putting a bimastoid incision, what happens is, you can open the scalp front and back. You can open the scalp flaps like this, front and back, open like this. When you open like this, scalp is open, done. Now you want to open the skull vault. How will you open the skull vault? To open the skull vault, you can use a saw, electric saw. We call it a striker saw. This is ideal, right? Many a times it's not used, but that's fine. So this is ideal, striker saw. But here what we can do is, you can put a V-shaped skull vault flap. Right? It will be like this. You want to have a V shape, something like this. There are variations of this, but this is commonly done. This is commonly done, V shape. So that after doing all the examination, if you want to reconstruct the body, if you want to close the body, so this skull cap is it's fixable. It's easily fixable, right? So this is V shaped skull cap will be opened. Skull cap will be placed. Fine. This was asked in one of your previous JIPMER exam question, right? Bimastoid scalp incision. Now you open the scalp, you open the skull wall. What is inside? Brain should be there, right? Brain will be there. Fine. So if you see the brain, how can you examine the brain? You can either examine the brain now itself, fresh dissection, or you can examine the brain after fixation with formalin. Right? What is the formalin that you will use? You will use 10% formalin. You will use it for at least 2 to 3 weeks. That is the ideal time for the brain to be fixed in formalin. If you ask me which is ideal, the ideal one is fixation with formalin. This is the ideal one. Not possible in all the cases. Right? Commonly done dissection is fresh dissection. Fresh dissection. And how would you open? The reliable technique is called a reliable method of cutting, that is called as cranial cutting method. Cranial cutting method, that is a reliable one. Cranial cutting method, that is most reliable method of examining the brain parenchyma. If you want to examine if there is any lesion or infarct or any other hemorrhage which is present inside the brain parenchyma, the best reliable one is cranial cutting method. So what is that cranial cutting method? Let us say if this is the brain, right, one lobe of the brain, so you can have cranial cutting like this, right, from cranial plane. In the cranial plane you can start cutting, that is cranial cutting. So the reliable technique is cranial cutting method. So do remember that is cranial cutting method. That is very important, right? Now this is for adult. This is for adult. Now we'll have to talk about fetus. We'll have to talk about fetus. This is the fetus that we have got. Let's say newborn baby or fetus. I told you earlier itself that the skin incision, you can start putting inverted Y incision. I told you this, inverted Y incision. Now, how about you open the skull vault? There are two methods for the fetus that we can practice. Number one, Beniki's method. Beniki's method, wherein we get two flap, right? Both sides. This side one, this side one. Two flaps only. Another one is Bohr's method. Bohr's method is something where we get four flap. Four, right? Front, two, and this side two. I'll show you that. You can have a look at it. This is the skull vault of a fetus. You can see if I am putting an incision from this side, right, from this side, like this, and if I am on the other side, I'm putting like this. So you get two flaps. This side one flap and this side one flap. Two sides. You can open like this. Some people call it as butterfly shaped, right? Because you get two like a wing. Fine. Another one, this is Beniki's method. I told you two. Another one, what we can do is you can just open, right? This is one, this is one, this is one, this is one. Right? Something like this. Wherein you get four flaps. What are the four flaps? This is one, this is two, three, and four. Four flaps are there. So this is your Bohr's method. Fine. So Beniki's Bohr, whichever is possible, we can use it. Now going forward, let us talk about, I have spoken about the brain. Now let me talk about the spinal cord. What you have to understand is, first of all, you need to understand that the spinal cord is not routinely opened. Remember, it is not routinely opened in all the cases because it is very cumbersome. That's the ideal reason, right? But the point is, if you suspect any spinal lesions, if you suspect any spinal tumors, if you suspect any spinal injury, then you need to open the spinal cord. In that case, you can either open it anteriorly or you can also open posteriorly. We call it as anterior approach, otherwise called as, another one is posterior approach. Anterior approach, posterior approach. Anterior approach is normally when you keep the body on the table, you start putting skin incision, open the chest rib, and you open, take all the organs, you examine all the organs from the abdominal cavity as well as the thoracic cavity. After doing all these things, then you start approaching, you cut the vertebral body from anterior itself, you can examine the spinal cord. You can examine the spinal cord. But one of the most important advantage of this anterior approach is that you can start examining the nerve root. Right? You can examine the nerve roots. You can also examine the dorsal ganglia. That is one important advantage. That is one important advantage, but this is very complex. Very complex. Very complex procedure. When it comes to posterior approach, it's very simple. Whether you open anteriorly or not doesn't matter. If you want to directly open the back, you can flip the body posteriorly. You can open easily on the posterior side. Right? So this is easier. But here also we have one important advantage. What is the advantage here? You can start examining the cervix. See, cervical region of spinal cord is very easily accessible. Right? Cervical region of spinal cord, it is not only easily accessible, you can examine the cervical region better in posterior approach. Better. Right? You can examine the cervical region of the spinal cord better in the posterior approach only, not in the anterior approach. And not only that, if you want to examine the brain and the spinal cord continuously, the continuity of the brain and the spinal cord will be preserved intact in posterior approach only. Right? You can examine as continuously. You can see the brain and spinal cord continuously. Right? As in continuity you can examine. That is again one of the very important advantage of this posterior approach. Anterior approach, posterior approach, I told you that. Complex one is anterior approach, whereas easier one is posterior approach, wherein still you can find out the cervical region of spinal cord very easily, and you can also find out the brain and the spinal cord continuously. That is again very important. Now let us talk about the another important organ, heart. A very important organ, right? Heart. So open the thoracic cavity, you will be able to find out the heart. Right? For everyone you can see heart, even though some people have given the heart to someone else, but still when you open the thoracic cavity, still you will be able to find out the heart. Right? There are so many approaches. See, you have lot of methods of dissection of heart. Right? So many methods are there, but I'm going to tell you one common method that we normally use during dissection. Right? That is called inflow outflow method. Right? Inflow outflow method. Right? Very, very simple. The word inflow, the word outflow. What is flowing in and what is flowing out? That is what you need to know. What is flowing in and what is flowing out? It is the blood that is flowing. So you are opening the heart along the blood flow, right? You know the blood flows in the heart, the flow of the blood in the heart. So it starts from right atrium, then it goes to right tricuspid wall. So first you examine the right atrium, examine the tricuspid wall, go to inside the right ventricle, examine the right ventricle, then go to pulmonary wall, then go to left atrium, mitral wall, and finally left ventricle, and finally the aortic wall. This is how it goes. What have you done here? You have done nothing except that following the blood flow. You are following the blood flow. That's enough. Right? Right atrium, right ventricle, left atrium, left ventricle, as simple as that. Fine. So this is called inflow outflow method. This is the commonest one. Do remember, it is an easy one to follow. The next one, right? Another one is called ventricular slicing method. Ventricular slicing method, which is also called a short axis method. Short axis method. What is that short axis method? You take the heart. What is that short axis method? You take the heart. Let us assume this is the heart. Fine. This is the apex. Right? This is the superior side. This is superior, this is inferior. Superior, inferior. What can you do is you can start cutting like this. Right? Short axis. You slice the ventricle and you can examine. That is called ventricular slicing method. There is one more method that is available, that is called, right, sandwiching method or intramural method. Sandwiching method or intramural method, wherein you are cutting along the muscle plane. Right? Suppose if this is the heart, right? The apex, this is the root. This is superior, this is inferior. You can start slicing like this. You can start slicing like this, like you cut the sandwich. Right? This is better useful for any kind of infarcts or fibrotic plaque in the ventricular muscle. You can examine. So this is meant for that. So this is called intramural method or sandwiching method, right? What you have to know, important one is, the most common one is inflow or flow. Fine, that's what you need to know. Now going forward, after the heart, you have to discuss about the stomach, right? How would you examine the stomach? You can see that, assuming that this is the stomach, you can say this happens to be the stomach, right? This happens to be the stomach, cardiac and pyloric. Now suppose if you want to examine the stomach, first you need to cut the stomach out. What you do is you apply two ligatures, we call it as double ligation. Why do you want to double ligation? The reason is very logical. You need to apply your common sense. If you are not ligating, just cutting the stomach and taking out, whatever that is present in the gastric cavity will leak out. Whatever that is present in the gastric cavity, is it important for your post-mortem examination? Is it important for your investigation? Yes, it is so important. What if the person has consumed poison and died? Right? Whatever that is gastric content is so important. You need to preserve it, send it to the forensic science lab. You cannot cut just like that. You need to apply two ligatures, cut in the middle, so that you preserve the gastric content and you can use it for the further examination. Right? Now, if you want to open, you cut the stomach out by double ligation, and you want to open the stomach and see what is inside. If you want to open the stomach and see what is inside, which side that you want to open? Do you want to open on the lesser curvature side, or do you want to open on the greater curvature side? You need to open on the greater curvature side. Open on the greater curvature side. Why? Because imagine the person has got food-filled stomach and he has consumed a liquid, that is acid. A person has come with acid intake in a food-filled stomach. What is the area of maximum damage? The area of maximum damage is along the lesser curvature. Remember, it is along the lesser curvature. That is the area of maximum damage. We call it as Megan-Stress, right? That is the area of maximum damage in an acid intake. So if you want to examine that particular area, you need to open on the greater curvature side. That was asked in one of your examination. Open along the greater curvature. That is important, right? Fine. Now going forward, other organs. What about other organs? Other organs, for example, liver. Let us say liver, right? You have spleen, you have kidney. So all these organs, visceral organs, how do you open? What we can do is you can start putting multiple parallel cuts like this, right? This is called multiple parallel cuts. You can have multiple parallel cuts on the solid organs, multiple parallel cuts, which is called as bread loafing method. Bread loafing method. Bread loafing method. Right? So this is what you can do it for the visceral organs, solid organs. Right? Right, while you do dissection, you need to preserve the samples, you need to preserve the tissues for further investigation. The commonest investigation that we do in a case of poisoning, that you send all the organs, relevant organs, to the forensic science lab, and we have a separate discussion on what organs to be preserved routinely, what organs to be preserved extra in different poisoning. Everything we have in toxicology, you can refer there when we discuss the specific tissues to be preserved in a particular poison. I don't want to duplicate the content. Right? Now, let us discuss some, apart from the poisoning, what are the organs that you can preserve. Primarily, if you want to do DNA testing, what is a sample that you can prefer? For DNA, the best one is blood sample. Suppose if the body has gone for early decomposition, body is decomposed, but it is early. In that case, what you can preserve is, you can preserve either the muscle or you can also preserve spleen. Suppose if it is late decomposition, body is in advanced decomposition state, in that case the muscle and spleen will not be useful. In that case, you can use bone, which is the last organ to decompose, tooth, which is the last organ to decompose, and you can also have some hair samples. From the root of the hair sample, you will be able to find out the DNA content material. Right? So this is for DNA analysis. So now we have one more important discussion, that is nothing but this, right? Body is completely buried already. You want to dig the body out. That process is called as exhumation, right? That process is called as exhumation, right? This is basically digging the already buried body, digging out the already buried body. That is called exhumation. Buried body, that is called exhumation. And it is lawful digging. That is very important. Otherwise, it is stealing the dead body. Lawful digging out the dead body, buried dead body, that is called exhumation. And this is also called as disinterment. Right? If they want to ask you in exhumation, but they want to make it little tougher, they can ask you the synonym, that is disinterment. Interment means burying. Taking out, that is disinterment. Easy to remember. I told you this is the lawful digging out the already buried body. When I tell you lawful, somebody has to authorize you. Right? Who will authorize? What is who is the official that can authorize this exhumation? It is the magistrate. You need the authorization from the magistrate. It is given by 174. Sorry, it is given by 176 3 CRPC. Very important. 174 IPC is meant for police inquest. 176 is meant for magistrate inquest. 176 3 CRPC. Right? While you do exhumation, right? The body was buried 5 years back. Can you do exhumation now? Yes. The body was buried 10 years back. Can you do exhumation now? You are in doubt. This is related to a criminal case. Body was buried 10 years back itself. Can you do exhumation now? Yes. The body was buried, the person was murdered and the body was buried 25 years back. Now only you got to know that that person was murdered and it is a criminal case. You want to do investigation. Can you exhume now after 25 years? Yes. In India, there is no specific time limit. There is no specific, there is actually speaking, there is no maximum time limit for exhumation. You can do after any number of years. There is no maximum time limit. But there are few countries where you have a specific time limit, like France, Germany and all, you have a specific time limit. But in India, there is no specific time limit. Right? And while you do this exhumation, you need to do it under the supervision. Who are the people should be present over there? Number one, magistrate, because magistrate has to authorize first of all. Magistrate has to authorize. The police should be there and the doctor should also be there. Exhumation should be done in the presence of these people. Right? It should be done in the presence of these people. And you see, it preferably started in the early morning itself, so that you will complete the process in the daytime itself. Right? If you want to study the color changes and all the skin changes and all decomposition changes also, it is better to do it in the daylight itself, so that you start in the early morning, you complete it in the daylight. Right? Now, while you are doing exhumation, do remember that you have to preserve soil samples. Why do you want to preserve the soil samples? Right? You need to preserve 500 grams of soil sample, half a kg of soil sample, right, from all the places. Right? Let's say, for example, if this is the dead body, right, you take a soil sample from the anterior surface of the body, posterior surface of the body, right side of the body, left side of the body, upper superior surface of the body and the inferior part of the body. So basically 6 samples that you've got. Anterior, posterior, right side, left side, superior, inferior, right? Headed and footed. So in all these places you take. You can say 6 samples and you would also like to take the control sample from that area. Why do you want to take control sample? Because you want to examine the control sample also. Why specifically that you want to examine the soil sample? Do remember, suppose if there is any poison which is present in the soil, preferably, usually it is metal. Right? You send let us say that you do exhumation, you take all these tissues, send it for analysis. Right? And you also send the soil sample for the analysis of forensic science lab. They are testing whether poison is there or not. Remember, if there are any poison, suppose let us say any arsenic. Right? I told you metal, right? Arsenic. If the arsenic is present in the body tissues, right? If there is arsenic present in the body tissues, right, you are not sure whether the person died of arsenic or whether the arsenic was present in the soil has gone into the tissues. We call this as post-mortem imbibition. Remember, it is called as post-mortem imbibition. It is imbibition of the poison from the soil into the body after death. That is why it is called post-mortem imbibition. Absorption of the metallic poison from the soil into the tissues after death is called post-mortem imbibition. You want to know whether it is post-mortem imbibition or not. That's why you take the soil samples along with the body tissues. Right? And I told you the most common metal involved in this is arsenic. The most common metal involved in this is arsenic. Do remember, that is again one of your important MCQ, previous year MCQ. How would you know whether it is post-mortem imbibition or the person died of arsenic poisoning? If the arsenic content is more in the body tissues and the arsenic content is less in the soil sample, that means person could have died of arsenic poisoning. If the arsenic which is present in the body tissues is less and the arsenic which is present in the soil sample is more, then it could be the contamination of arsenic from the soil into the body. Right? So you basically have to compare. That's it. You basically have to compare and find out it is a case of post-mortem imbibition or not. So this is called exhumation. You need to take all these soil samples, right? And the back as well. And you also take the control sample. Fine. So all these things you do, this is basically exhumation, the lawful digging out the dead body, right? Digging out of the buried body.